There's a child in a New Jersey hospital who is clinically ready to go home. Patient is ready to be discharged, not almost ready, not maybe next week. They're ready. The discharge plan is written, the equipment can be arranged, the family wants them home, the care team wants them home, and the health plan has authorized private duty nursing hours. But there's one missing piece: no nurse. So the child stays. Not because the hospital is the right place anymore, not because the family failed to plan, not because the doctor forgot the order. The child stays because the home nursing network on paper doesn't match the home nursing network in real life. If you want to understand what is broken in Medicaid managed care access, don't start with a dashboard. Start with that discharge planner trying to find a pediatric home health agency that can actually staff the case. Because on paper, New Jersey has hundreds of home health agencies. But when we reviewed the NPI registry for pediatric specific home health designations, the number of dedicated pediatric home health agencies looked closer to 8 out of 200. And even that number includes nuance. For instance, BAYADA and Maxim serve pediatric cases, but they're not exclusively pediatric. The agencies that surfaced as pediatric specific included names like Affirmed Home Care Pediatrics, Pediatrics and Adolescent Therapy Associates, Active Pediatrics Therapy Services, Growing Hope Pediatric Care, For Kid Care, and Family Care Agency. This is not a published government statistics. What we've done at Carenodes, at my company, to actually enumerate the network scope as it relates to pediatric home health. And when the network looked so broad on paper, it became a little bit of a head scratcher because it started to point to a much bigger problem. When the network looks broad on paper, but families still cannot get care, the question is not, do we have enough providers listed? The question is, can a child actually get home? I'm Alex Yarjanian, and this is the Value-Based Care Advisory Podcast. Today's episode is about pediatric home health, private duty, and one of the most important access problems in Medicaid managed care. That's the gap between authorized care and delivered care. Because in Medicaid, authorization is not the finish line. A health plan can approve private duty nursing hours, a hospital can discharge a child, a family can be ready. But if those hours go unfilled, access has failed. And this is where the story gets uncomfortable for managed care organizations, regulators, and provider networks. Nationally, the MACPAC, they go unfulfilled. Meaningful share of authorized private duty nursing hours go unfulfilled, often cited in the 20% to 40% range. This isn't a New Jersey specific figure, but it captures the scale of the access failure. If a medically complex child is approved for 80 hours of nursing a week, and 20 to 40% of those hours are not staffed, that family is not receiving the benefit that we're authorized to receive. They are receiving a promise with missing labor behind it. So managed care has a habit of treating provider directories as if they are proof of access. A directory says there are providers. A network adequacy filing says the plan meets the standard. A contract says the service is covered, but pediatric private duty nursing exposes the weakness in that logic. A provider directory can include agencies that 1. Do not take new pediatric cases. 2. Do not serve the child's county. 3. Do not have high acuity cases to be staffed. I'm going to stop enumerating them because they're on and on. They do not have overnight nurses. Do not accept the plan's reimbursement.